Welcome to the September edition of the joint collaboration between ICCAC and MyLVAD for the Journal Club. We are honored to be joined by Brian Widmar, PhD, Dr. Widmar from Vanderbilt University's School of Nursing, and he and his collaborators researched how VAD patients are educated and how that education is organized and provided. The paper was recently published in the Heart and Lung Journal, which is the journal from American Association of Heart Failure Nurses. And Dr. Widmar, we are honored to be joined by you, and please shed light on how this paper was written and your research. Thank you very much for joining us.
Okay. Well, thank you for inviting me. I'm really excited to talk about this article that got published in January. And it was just a study to look at self-care education delivery in ventricular assist device programs in the United States. I have nothing to disclose, no financial associations or anything. And I hope that by the end of my covering these slides that you'll have a better understanding of the organizational structure and specific professional roles that are present in United States VAD programs, and then be able to describe methods of education delivery and skill performance validation that are being used. So I thought I'd give you a little bit of background about me. I'm originally from Birmingham, Alabama, so I have worked in 2 or 3 hospitals that had pretty active VAD programs. And so this research was a 2-part study. This was my dissertation work from my PhD here at Vanderbilt. And so what was published was actually the first half of my work, looking at structures and education delivery as well as validation methods. The other part was doing patient interviews with VAD patients and families and getting an idea of their satisfaction with their education and preparation for transitioning from hospital to home and their perceptions of patient-centered care. Dr. Mary Dietrich is a co-author who was the statistician, and Dr. Ann Minnick is the Dean for Research here at Vanderbilt, and they were my co-authors on this manuscript. So, you know, I have to say that I'm going to just briefly touch on how the study was set up and how we carried things out, but I'm going to focus most of the time on the results. And no article is complete when it's about heart failure or VADS without touching on the incidence and prevalence of heart failure. But what was interesting, you could see the numbers when I started my doctoral work versus when I completed the research. You can see that the prevalence and incidence continues to increase, but the latest stats show that we're going to see a dramatic projected increase of prevalence of heart failure to over 8 million by 2030, and that's expected because of the aging of the baby boomer generation. And even the AHA's latest statistical summaries point out that 10 out of every 1,000 individuals over the age of 65 are going to be newly diagnosed with heart failure. And since we have ever-increasing indications for VAD therapy, whether it's a bridge to decision or candidacy or transplant or DT, there's a lot more VADs being implanted than there have been previously. And looking at the Intermax registry of annual implants from 2007, comparing that to the 2013 numbers, it's a pretty significant increase in how many VADs are being implanted annually. And I became interested in self-care processes because the qualitative research that I had read really talked about the anxiety and the uncertainty that patients and families faced when they first went from hospital to home. And they were intimidated by having to assume care of like a life support system. And the regimen that, I mean, we all know the regimen that patients and families have to learn, the daily tasks, the wound care. It's complicated, and it can be intimidating to patients and families when they first go home. From my own professional experience, when people ask me why I became interested in this topic, I tell them that I had a patient as a bedside nurse who he and his wife had done everything that they needed to do to validate their own self-care, but when it came to the day of discharge, the patient's wife disappeared and didn't return to the hospital for 3 days because she was absolutely terrified to take him home, even though she did everything like a pro and picked up everything, was very, very bright. Deep down, she was absolutely terrified because she didn't want to make a mistake and cause him harm. So based on my own professional interest and then looking at the literature, I wanted to look at how we prepare patients for self-care. And in looking at the literature, I found that we don't really describe how VAD patients learn their self-care skills. We don't discuss how self-care education is provided and what resources we actually use to provide it. And then we don't have a good grasp of the extent to which type of education, method, or who provides it actually influences patient outcomes like readmission rates, device complications, or patient satisfaction and quality of life. And so this study's aim was to describe care structures and self-care education processes used in VAD hospitals. And you've seen this model in the article. This is what guided the concepts that we developed for our survey and the concepts that we wanted to measure. And this is the Minnick and Roberts outcome model. And the shaded areas are what I focused on in my survey development. And this model describes a series of administratively mediated variables, or variables that leaders and stakeholders can manipulate to influence the patient-provider exchange and ultimately influence or shape patient outcomes. So just quickly, this was a descriptive cross-sectional design. We received IRB approval, and it was designated as an exempt study. The concepts were operationally and theoretically defined based upon the conceptual model that we used and the literature review and clinical expertise. And so we wound up developing a 26-item questionnaire, which some of you might find familiar. And it was called the VAD Services Survey. And so this is the table straight out of the article. And you can see the topics that we covered, just two big topics: care delivery structures and self-care education elements. And the variables underneath those or next to those are consistent with what were listed in the conceptual model. And then on the far right-hand column are the items that were included related to their respective variables, like organizational facets, employment terms and scope, labor input, capital inputs, and employee behaviors. So my sample basically was I wanted to get information from every adult VAD hospital in the United States, and that was not an easy task, trying to find everybody. So I had to be creative. The first place that I looked at was the International Consortium for Circulatory Assist Clinicians listserv. They have a membership directory, and so I organized by state, which was really convenient. And I've been following that listserv for a while before starting the PhD program. And so I knew that was a great place to start to find contacts for VAD programs. So I looked at that membership list and I cross-checked it to the CMS approved list of DT, destination therapy programs. And then I also compared that to active hospitals that were registered with Intermax. And so I crossed out duplicates and inactive programs. And then just to make certain that I had tried to find everyone, I cold called people by actually Google searching all 50 states followed by VAD programs. So I found a couple extra programs in Maine and New Mexico that weren't in these lists. And so I excluded pediatric programs. I wanted adult learners, and I wanted hospitals that focused on or that deliver care for HeartMate 2 implants. I wanted to stick with one set of skills and methods that had to be used, so not to complicate, but I wanted to find out what hospitals do to train patients to manage this one type of VAD. And then I decided I was going to try to connect with VAD coordinators because looking at their role in addition to other members of the care team, the VAD coordinators to me seemed to be the ones that had the broadest perspective of the patient experience from pre-implant until the patient death or transplant or for whatever their trajectory entailed. So they saw the patient across the continuum and could speak more to the way programs were set up. So they seemed like the professionals that could give me the most robust information. We sent out paper surveys, and I had an electronic version too. So as to entice coordinators to complete whichever method was most convenient for them. So I first made an internet announcement on the ICCA listserv, and then sent self-addressed stamped envelopes with the surveys included with a link provided as well if they wanted to take the internet option. And I did 3 mailing cycles about 3 weeks apart just so I wouldn't get on anyone's nerves. And I linked the hospitals that I sent the survey packets to reported information that is provided by hospitals to the American Hospital Association annual sample survey. And they track information like resources that are made available and then demographics for hospitals like region, bed size, ownership status, and then whether or not the hospitals were teaching facilities. Because I was wanting to look at administratively mediated variables which could influence the way resources were used. The Research Electronic Data Capture tool is a grant-supported data repository and survey deployment tool that Vanderbilt uses. And so I did use that to collect data, and I inputted written completed surveys into that, and it downloaded really nicely into SPSS for statistical analysis. And then you can look at the article to see what statistical tests I ran for what data I analyzed. But what I did do was just to see how generalizable my final sample was, I compared statistically my responding hospitals to my non-responding hospitals and found that there was no statistically significant difference between the two, just to make sure I didn't have a sampling bias. And I did not. What I did get was a great response rate. Usually in the literature, you can expect from surveys to get 25 to 30% response rate. I got 64. So I identified initially 124 adult hospitals that were active at the time I did the study. Excluding pediatrics, duplicates, and inactive programs, I had a final sample of 71 in the United States. So I got, 111, and I got 71 to respond to it. So that's a 64% response rate. I had very little missing data, and in fact, the only missing data that I had were financial questions that I had asked, and some coordinators were not allowed to disclose that information. So some actually apologized for not being able to give it. So I had very, very little missing data. Like I said before, there was no statistically significant difference between responders and non-responders. So it was a well-represented final sample. But the service volume, the number of implants that hospitals reported for the current year, the median number of implants was around 19 to 20, with a minimum reported of 0 and a maximum of 85. At least 50% of programs in each region responded. 73% were non-government, non-for-profit, and the majority of hospitals were large hospitals with over 500 beds, and most of them were teaching facilities. So from the survey data, the first thing I looked at was the capital inputs, or that was defined as resources that the hospital may invest in or might be provided to them by device manufacturer. So what resources are actually used to deliver education to patients and families? And looking at this table, you can see that the majority, starting from 89% up to 96%, it was usually written material that was provided by THORTAG, or the DVD that comes with it, or written material that had been adapted from that information by the hospital, in addition to verbal instruction. 40% of hospitals used, most of the hospitals used combinations of those. 40% used 2 or fewer materials or activities. One interesting, at the bottom of the table, one interesting fact that I found out was 17% used other methods like password-protected YouTube videos of skill demonstrations and high-fidelity simulation. And so when I was thinking about the teaching process, I wondered if our perceptions of what we thought was most difficult for patients and families wound up getting the majority of our time. The first thing I thought of was if we have if we believe that certain skills are harder for the patient and family to learn, we might spend more time focusing on those. But we might not actually know if that's what the patient and family thinks is most difficult. So what we think is most difficult might not be what they do. So I asked coordinators to rank the level of difficulty of certain skills on a 1 to 4 scale, 1 being not difficult or fairly easy, and then 4 being really difficult and takes a while to master. And this didn't surprise me, and it probably doesn't surprise you, but sterile technique and dressing changes were at the top of the list as being the most complex. There were some that were not applicable, like hemodynamic monitoring, meaning blood pressure monitoring. Alarm troubleshooting and emergency management followed. And then at the top, the skills that look like they have to be performed regularly, like every day, self-testing, battery changes, power source changes, and so on, were some of the easiest ones they felt that the patient and family had to learn. And then I wanted to know, well, if we're using these resources and we have an idea of what we think is most challenging for the patient and family, well, how do we validate their skill performance? What do we do to deem them competent and safe to go home and self-care? And looking at the list of skills again, similar to the previous slide, I asked coordinators to report if they used return physical demonstration, return verbal demonstration, written testing, oral testing. And there's a lot of variability in the reports, and it suggested that a lot of coordinators use combinations of validation methods. But looking again at the list of skills, these are in order of return physical demonstration because I had a specific focus on that. The skills that patients have to do day in and day out were most likely to be done using return physical demonstration, whereas I'd like to point out the alarm troubleshooting and power source changes were most often validated using a return verbal demonstration. And then looking at patterns, usually it was one of those two methods followed by oral testing. And then looking at patient support, what organizational resources do we use for VAD patients and caregivers as they transition into the community? Not surprising was counseling of some form with support group meetings, use of the hospital websites. A lot of hospitals had VAD resources or referred patients to internet websites, and then patient provider email correspondence was pretty common. Some of the additional things that not all hospitals offered were things like patient picnics and social gatherings, the use of social networking, internet listservs or discussion forums or chat rooms. And then I shifted focus to see how hospitals' programs were structured to support the education delivery. And so what I found from looking at the hospitals was that more than half of VAD programs reported to 2 different departments, 2 or 3 different departments. Most often that was a heart failure division and a surgical division. There was also a department of transplantation that was often reported to as well. Over 75% of VAD coordinators reported to 2 or more administrators. And that was usually the medical director, surgical director, transplant director, and then sometimes there was a administrative director who was typically a nursing administrator. The patient to coordinator census was not unlike what has also been in the literature. A median, this is heavily skewed, but a median number of around 15 patients per coordinator. The range was interesting with some reporting as few as 2, but as many as 40. But often these were patients who were not just in one area. This was across the entire trajectory. So there were patients that were being followed in the community in addition to the ICU and the subacute areas. I wanted to know who the team players were, who made up the VAD team. And then I wanted to know their level of involvement. So these are row percentages, and you can see the different team members that I've worked with in my time and who I've seen discussed in the literature. Most, it shouldn't be surprising, but the most of us are regularly assigned to the VAD program, but we also have to work with other kinds of patients. It's very rare to see a dedicated VAD service or unit with this set list of professionals. And then it was interesting to see that there were some professionals that were reported that had no involvement in the VAD team or VAD patient care. Like almost half reported they didn't have a clinical nurse specialist who was involved. And then like 17% for biomedical engineers or clinical psychiatry were not routinely available to the VAD team. I also wanted to look at a closer look at caregiver roles. And so just some of the clinical services that, again, clinical experience and then looking at the literature were very often provided for patients during their inpatient stay and then prior to being discharged. And again, this is probably not surprising to you either, but the APN who was not in a coordinator role was more often completing the medical-related tasks like ordering drug therapy, nutritional support, and diagnostic testing. They also shared that responsibility with people in blue at the far right of the screen, which were like fellows and residents. And then the VAD coordinators did have a role in some of those ordering systems, but they were largely responsible for VAD settings and then preparing for the transition to home, like recommending social support and home health. And then they were very much responsible for teaching and evaluating self-care. But it looks like there was some overlap with other providers, which suggested that there was sort of a team approach to that self-care training. And so given that, I wanted to take a closer look at what all the VAD coordinators were expected to do in their given roles. And so looking at this, the left side of the table, basically anything that has to do with VAD education, the coordinator is responsible for it, whether it is training EMS personnel, training house staff, training nursing or patients and families. The development, implementation, and evaluation all seems to fall on the shoulders of the VAD coordinator. And then there were some things like entering database entry of clinical data, maybe the Intermax registry, direct care nursing. There was some involvement at the advanced practice level. Inventory of equipment was reported often too. And then other at the bottom was actually setting up networking with outlying heart failure clinics, sort of creating a network and reaching out to increase referral bases. And then the last analysis that I did was, given all that, I wanted to look for patterns a little bit more closely, specifically patterns of additional resource use. And then I wanted to look for differences between labor input, the sum of care providers on the VAD team, versus demand, or the actual number of VAD implants in the last fiscal year. And this was one of those areas that were financially sensitive that some coordinators weren't allowed to give me that data. But I looked at clusters depending on, related to capital inputs, support processes, in addition to labor and demand. And so I'd like to note that the additional materials used for education outside the Thoratec materials or things that the units created, who was using a wider variety of additional resources. And so there was nothing, that two clusters emerged from this final sample. So the only statistically significant finding was in support processes. There was one cluster that seemed to use a variety of additional social support mechanisms, like using internet listserv, discussion forums, and social networking sites, versus the second cluster of hospitals, which didn't use anything additionally. And then labor, pretty much the same, 81 to 83% were providers that worked regularly with the VAD program but had other responsibilities. And then the number of VAD implants were similar between the two groups. So some discussion points from the results. Like heart failure self-care, VAD self-care includes both tactical and situational skills in order for the patient to manage themselves effectively. And we know from qualitative studies that this is a process or a transition that occurs over time. The patient isn't discharged as confident as we would hope they would be, but over time they adjust and become more confident in their self-care abilities. Verbal instruction and manufacturer materials are most popular methods chosen for teaching self-care. Return physical demonstration was used most often in regularly performed skills, while return verbal demonstration was used most often in infrequent or situational skills, like alarm troubleshooting and emergency. And while none of this data was related to outcomes, so I couldn't speak to whether one method is effective or not, studies do suggest that there's an increased anxiety or apprehension related to being able to perform psychomotor skills in situational events in the event of like complications. And if you remember Benner's novice to expert model, building off of Dreyfus's skill acquisition theory, novices tend to be those that can follow tasks and can follow a structured series of tasks day in and day out, where advanced beginners begin to question and understand the reasonings behind why tasks have to be formed and begin to problem solve. And so one question that came from this was, are we doing enough to prepare patients for going home at the advanced beginner level where they can effectively manage themselves during situational events like alarm troubleshooting or emergency? And is return verbal demonstration the way to assess that knowledge? Looking at psychosocial support, there is an increasing use in social networking and virtual support communities. Heart failure literature is showing an increase in telemonitoring as well as internet-enhanced methods to communicate between provider and patient. And I think it's just a matter of time before we see that being developed for the VAD patient population as well. I also found that the leadership and reporting structures are very numerous and complex, and having to report to multiple people who each have their own set of expectations for what your role should entail can cause some blurred or unclear definitions of what's expected of you, which could in turn impact performance. We know that core teams are multidisciplinary and they're responsible for VAD care in addition to other patient populations, but there was quite a bit of variability into who were key members of the VAD care team. So one question that we could ask is, who are the essential team members, and are they persistently and consistently represented in VAD hospitals? And what is their defined role in VAD care? Is there a lot of overlap between what's expected of different professionals? Do we get in each other's way, or are we giving our most effective contribution to VAD care? And again, with this wide variety, it could potentially impact performance of specific role elements, like patient education. We still don't know if coordinators are supported enough or prepared for the burden of developing education curriculum for multiple professionals and patients and families, as well as implementing that education and then evaluating it. That's really important to make sure that our coordinators, who have the lion's share of educating anyone that comes in contact with the VAD, are set up for success and can do this work most effectively. We don't know if the current methods of education that I found in this research actually impact patient outcomes, and to what extent. Is one method of delivery better than the other? Are patients ultimately satisfied with the training that they receive? Maybe we should let patients actually tell us what we're doing that works for them. And does satisfaction actually impact other outcomes like readmission rates, device complications, and quality of life? There is a potential that some hospital programs popped up during the study that I didn't identify. Some of the results weren't linked with patient outcomes, so I can't compare effectiveness of any given method or teaching or validation. And then while we believe that the coordinators had the best perspective to give the most accurate information, there's always the potential for inaccurate reporting of variable descriptions, especially at the administrative level. And in closing, I think it's time that we take a closer look at the elements of self-care education of VAD patients and their caregivers. And up to this point, the research emphasis has been on, because of innovation and evolution of pump technology, on morbidity and mortality, cost effectiveness in comparison to transplantation, as well as quality of life. But now we need to explore our care quality and the nursing's role in all that, and in patient care, and then those relationships to patient outcomes. And thank you so much for the opportunity to talk with you about this manuscript, and feel free to email me if you have any additional questions later on. Thank you.
All guests have been muted. All guests have been muted.
All right. If everyone can give me 2 seconds, I am unmuting everyone's microphone. And if there are any questions for Brian, you feel free.
Brian, I really want to thank you for driving us in a new direction and really, as you said, looking at exploring the quality of the care we give. And that's going to be really important. I hope we could find a way to collaborate in the future MyLVAD is going to be offering a patient satisfaction survey tool, which will be operational probably September 15th-ish. And we'll be getting some of that data back, so that's the perfect tool to use to evaluate. I'd be interested to hear what Lori or Krista think about this. And Leslie. You guys still here?
They're unmuted. I don't know why they are not responding.
Maybe they finished up for the day. But it was an amazing presentation. You touched on a lot of very important elements of things that we need to be considering and collaborating on. And I look forward to discussing the opportunity to do that, especially as we do sort of blow up this patient satisfaction tool, which is going to be something that we can use to evaluate what's going on. Thank you so much, Brian, and for everyone who's joined us. And then,
hey, Tanya, it's Leslie. I just want to apologize for having come in late and just also thank Brian. You did a great job. I'm sorry I didn't hear all of it, but I'll go back and catch the recording. And I think you're right, Tanya. I think the survey at MyLVAD would be a great opportunity to get some more feedback and guidance on how we can improve.
This is great stuff, and this is really falls solidly in the VAD coordinator domain, so I'm excited to think about ways we can push ahead with it. All right, everybody. Well, Brian, again, thank you so much. It was fantastic. I was taking fast and furious notes.
Thank you for the opportunity to talk with everybody. I really appreciate it.
All right, all. Have a great day.
Bye.
Bye.
Bye.